Welcome to today's ME SUD Learning Community webinar. Today we'll be hearing from Dr. Kenneth Minkoff on strategies for psychopharmacology for individuals with co-occurring psychiatric and substance use disorders. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker of this PMP webinar are their own and do not represent the positions of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. And now I'd like to give a quick introduction to our speaker today. Dr. Kenneth Minkoff is the Vice President and Chief Operating Officer Senior at Zia Partners, Inc., a behavioral health system consultation firm in Tucson, Arizona. He is board certified as an addiction psychiatrist and community psychiatrist. Dr. Minkoff has been recognized as a national and international leader in strategic development of quality-driven managed behavioral health care systems and integrated services and systems for complex populations for over 25 years through the development of a comprehensive continuous integrated system of care approach initially developed in the 1990s as a system design model for implementing integrated services for individuals with co-occurring mental illness and SUD. And with that, I'll hand it off to Dr. Minkoff for a presentation. Thank you all for being here today.
Thank you very much, Bethany, and thank you all for coming to join this presentation on the strategies for psychopharmacology for persons who have co-occurring mental health and substance disorders. And so a couple of things that I would like to say at the beginning to kind of ground this presentation. So first of all, I did another presentation on the basic approaches of welcoming integrated services for people with co-occurring conditions a few weeks ago, and Bethany is going to put the link to that in the chat. We have recommended that as something to look at before this video, but in case you haven't done that, you can go back and look at it after, because I'm not going to go over those basic principles. I'm going to be building forward on them and applying them to psychopharmacology. Secondly, the presentation, while it's oriented towards psychopharmacology, is designed to be relevant both to people who prescribe medications and people who work with people who are on prescribed medications, but who do not themselves prescribe. And I think we have a mixed audience, so hopefully this will make sense to everybody. There's an awful lot of material to cover. You will not know everything there is to know about this topic at the end of an hour. So I've provided additional materials that Bethany will be making available to you following this presentation. There are materials that SAMHSA developed over a decade ago around principles of psychopharmacology. There's an article I wrote in 2013 on this that although some of the medications have changed, the basic approach is not any different, and that provides more detail. There's some material from something called the SMI Advisor around how to organize integrated services for people with co-occurring conditions in the SMI world and mental health world, including a component that's focused on medication treatment for addiction. And then there's some material on screening that's very broadly applicable, and a particular screening tool that's referenced in that screening material. And that's also from the SMI Advisor. So you have a lot of stuff that you can reference as we go. So what I'm going to start with is building on the principles of the first thing. The thing I want everyone to keep in mind is that although psychopharmacology discussions get to be very focused on which medicine do I pick and how do I prescribe it, What I'm going to be talking about is the overall approach to working in partnership with people who are receiving medications for one or more conditions, and how that informs the way you think about your relationships with those folks and how you move with them in the direction of making decisions about what to prescribe, and how to help them think about, where the use of medications fits into their own journey in terms of addressing both of their conditions, as well as having some content around what kinds of medications are recommended for whom in what circumstances. So let's start with the basic principles. In the previous discussion, the previous video that I recorded, we talked about the idea that there are 6 basic principles and associated interventions that inform all work in all settings for all people with co-occurring mental health and substance conditions. And by that, we're talking about any person of any age with any combination of any mental health issue, including trauma, and any substance or addictive issue, including gambling addiction. And the first principle is, and so what I'm going to be doing here is applying those principles to the idea that you're working with people in a psychopharmacologic relationships. You're a prescriber. And so the first thing that is important is that co-occurring is an expectation, not an exception in general. And you should be expecting that in the people that you're working with. And so if you're prescribing for mental health, you should be expecting that you're working with people who may have active substance use. And it's important that you develop a framework for engaging them appropriately and recognizing that as a prescriber, you are an important partner in helping them address both issues going forward. And it's much more than simply telling them that you don't recommend that they use substances, or that you'll be unhappy with them if they're using substances, because that will likely result in their deciding it's not smart to tell you anything about their substance use, which gets you off to the wrong foot right at the beginning. So that the starting approach is being very clear that you know that most of the people you're working with may be using substances or have thought about using substances. Everybody is making substance decisions. And that you welcome the opportunity to work with those folks as a prescriber and help them figure out how to utilize medication and to make good decisions about medication and using substances in the service of helping them make progress toward their goals. In the spirit of this, you want to be organized about your own screening process, which is more than just screening tools, to help you identify co-occurring substance use, as well as I'll get into, substance misuse and substance use disorders, and keep track of how many people you're serving who do have co-occurring issues, so that is present clinically, and people who are working with the clients you're serving can see that those issues are present and be partnering with you to address them, as well as ensuring that that information appears in the data system so that the whole system can have good information about what you're actually working on. And if there's nothing else that you do leaving here, it would be helpful for you to go back and review who's in your caseload and actually begin to move in the direction of defining some good information about who you're actually serving to convince yourself that co-occurring is in fact an expectation in your own population. The second principle is that once you've welcomed people in and identified their issues, the key to helping them is building a relationship in which you're working with folks over time. And it's very important as a prescriber because you're wanting to move away from the idea that somehow you're going to find the magic bullet that's going to fix everything, and all you have to do is get them to do what they're supposed to do, and then it'll all be fixed. That it just doesn't work that way, and the more complex people are, the less likely it is to work that way. The best possible results with people with complex needs involve moving slowly with them over time in small steps, and successful interventions that move from when you meet people who may be disengaged to when they're ultimately achieving some prolonged abstinence may take 3 or 4 years. And so it's important to figure out how to go slowly in this process and build relationships that are empathic, that you're listening to people's stories and experiences. You're making a point of understanding where their hope comes from, because their hope is the thing that will drive them to change. That you're helping them as a partner with both issues. You're identifying things they're doing right and thinking of them as recurrently successful as you're working forward with them around their medication decisions and their substance use decisions. There's a framework for assessment that is built on that I'm going to talk about shortly. The third issue is that all people with co-occurring needs are not the same. So it's important to distinguish in the way you're thinking and intervening substance misuse from mild substance use disorders, from severe substance use disorders, understanding that substance use disorders are brain diseases in which the brain becomes addicted to its own internal states of getting high. And that even when people choose not to use substances, they often don't realize that their brain is on the other team, just like with other types of mental illness. And they need much more help than they usually know they need, including medication when it's available to help them gang up with their own brain to be successful. Similarly, it's helpful to distinguish normal painful feelings, which we do not medicate, from mild to moderate mental illnesses, from more serious and disabling mental illnesses, in the way that we approach the sequencing and prioritization of what we do. As a prescriber, we think both conditions are primary, and I'm going to go through a little, no matter how they got there. If the condition is persisting over time, you consider it a primary condition. If it's present in the moment, you consider it a primary condition that needs attention. And the best interventions are the best interventions for each primary condition at the same time. We recognize that in the work we do, even within the medication realm, that people may have multiple issues, but they may be in different stages of change for each. And that those of us who are prescribers have enormous capacity to help people who are coming to us for medication for one thing, like mental health, to be moving through stages of change for their substance use. And prescribers often feel powerless, not recognizing that they may have disproportionate potential if they approach people as helpful partners in influencing folks to move through the stages of change for the co-occurring condition and make better decisions over time. The final principle, so that what this is called is integrated stage-matched interventions, where you may be engaging in an active intervention for one thing, and then doing motivational strategies for another thing. And often helping people think about their substance use decisions in relationship to what they're hoping to accomplish in their broader life goals, as well as what they're hoping to accomplish for their mental illness, and helping them think through what are often difficult decisions, is a very valuable strategy when you're working with people around their medication issues. The final principle is remembering that our job is not just to tell people what to do, but even when they're making change, to help them develop the skills they need to succeed. And that's incredibly important around both the skill of taking medication appropriately, but also the skill of working with us so they learn how to help us and we learn how to help them help us be effective partners in communicating what's going on and working with us incrementally to find the best medication interventions to help them achieve their goals. So thinking about this as not an opportunity just to give people instructions, but to help them learn how to work with you and how to use their medication properly and how to report side effects and, feel comfortable telling you when they're using substances and discuss the pros and cons of how that's working for them in a way that feels comfortable. Those are all very important skills that as prescribers, we want people to develop. So this is the underpinning of all of the discussion to follow. Okay. And what we realize is there's not a single strategy for everybody. Interventions have to be individualized according to which specific co-occurring conditions you're treated. Co-occurring is a complex population. What are people's most important goals? What is their stage of change for each condition? What supports do they have, including other team members you may be working with? The acuity and severity of each issue, both in the moment, when you're dealing with a crisis and over time, the strengths and capacities they have, the skills they currently have to deal with medications or making changes, and whatever external contingencies may exist that influence the way they make decisions. So, so one of the things that people often use to do a quick categorization of people with co-occurring conditions is this 4-quadrant model. And the thing that I just want to emphasize about this is that in the mental health world, you're likely to be working more commonly with people who have more severe and persistent or disabling mental illnesses with all kinds of co-occurring substance use issues. And what we used to call substance abuse and what we now call substance misuse are people who are using substances on purpose, in control, perhaps normatively compared to their age-matched peers, but are using it harmfully. And for people with severe and persistent mental illness, harmfully is in relationship to the fact that they have a severe mental illness. And any persistent, because their brains are inherently fragile, any persistent substance use is unwise in the sense that it tends to discombobulate that fragile brain and interfere with, achieving the best outcome for the disorder, even though in the moment it's not causing dramatic consequences, or it's, the person tells you, well, I know I have schizophrenia. All my friends smoke marijuana. I like smoking marijuana. It makes me feel better. And that is still defined as substance misuse. And our job over time is to help people make better decisions about that. And as a general rule, one of the things that's helpful to let people know is that each time they use a substance in a way that helps them, quote unquote, feel better for a period of time, they're generally affecting their brains in such a way that when the substance use stops, there's a bit of a rebound. And the feeling or whatever that they're, quote unquote, self-medicating with their substance use is gradually going to get worse. So if you're drinking to relieve voices, when it rebounds, the voices get worse. If you're drinking to relieve anxiety, when it rebounds, the anxiety gets worse. This isn't like immediately obvious. It just happens over time. And what it creates is tough decisions for the people you're working with to make. Because, if you say, well, will I feel better when I stop? The answer is, in the short run, you'll likely feel worse. But if you keep using over time, the thing you're trying to relieve is gradually going to worsen. And so that's a tough decision. And in the long run, I would recommend that you stop, and we work with you to help you develop better ways of addressing those needs. But it's tough, and we can't say that it's going to be easy. Even for people who are using substances in a misuse, which implies that they're just making purposeful choices, and we can help them make better choices. For people with substance use disorders, as I said, once you develop a substance use disorder, the key element of that is the experience of losing control of your substance use in the face of harmful consequences that you recognize and you are trying to control your use to avoid. But you can't consistently do it. And the more severe your disorder is, the more progressively out of control you are, and the greater the severe consequences. But it's very important as we're talking to people that we recognize that when people have a substance use disorder, as I said, and they decide, which could be difficult, that they may want to stop or reduce their use, their brain is still on the other team. So we need to be partners in helping them figure out not just why they want to stop using, but how they're going to get the help they need to gang up with them against their own brain to be successful, including how we might use medications in the spirit of doing that. So I'm going to move on from this slide. Now I'm going to talk about the frame of assessment. And what I want to do here is emphasize certain things about how to do an assessment from the perspective of making psychopharmacologic decisions. And this is not the whole comprehensive discussion about doing an assessment, but this is based on work that I've been doing for decades, and it's kind of how I approach people to if I'm going to make a psychopharm set of decisions, what are some of the things that are really important for me to do? Assuming that I don't have an enormous amount of time and I want to focus on what's most important. And so part of what's important to realize in this process is that, it's helpful to have some idea about diagnosis, possible diagnosis, et cetera, when you're trying to figure out what medications to use. Our job is to medicate illnesses, not medicate feelings. And so we're trying to understand what's actually going on. And a lot of folks have been taught, and I would say incorrectly, that if you meet people who are, have active mental health symptoms and active substance use, that somehow you have to put off the assessment because the substance use per se may confuse the symptom presentation. But one thing I want you to take away is that that's inaccurate. Assessment of people with co-occurring needs often occurs when people are actively using and is based primarily not on their immediate symptom presentation, but primarily on their history. And history will give you the diagnosis the vast majority of the time, no matter how the person looks when you see them. And the history may come from them. It may come from previous records. It may come from other people who know them. Often you get great historical information as a prescriber from other people on your team who have been working with this person over time. But it's just, people who may have had schizophrenia for years, if they show up drunk, then they're a person with schizophrenia who is drunk. Okay. And they need help for their schizophrenia just the same as if they weren't drunk. So understanding the history and recognizing that diagnoses persist over time and need attention over time is important in terms of determining how you engage people. So within this framework, you begin discussion right away. And the discussion begins with welcoming and hope. It helps to listen to the person's story and understand not just their symptoms, but their life. So you understand the symptoms in context. During the process of gathering their story, you're screening for the presence of risk. And I often will be asking people where their substance use fits into their life and how does it affect their day-to-day, activities and things that they do to help them get through the day, and what works and what doesn't work, and how are they being successful. And I'm always looking for strengths in the sense of what is it that you're doing right for each issue to help you survive and how amazing that is. And one of the things that I'm particularly interested is the periods of time when you may have been successful. And I'm going to explain more about that as we go through. So, so in the process of screening, there's material on screening in as I said, that's attached to this presentation. But, practice being as welcoming as possible so that if somebody tells you that they're using substances, you're happy, and you let them know that you're happy that they shared that information. And then you want to be curious about how they make their substance decisions and how it fits together. And almost everybody knows that using substances is not a good idea. And how they internalize that information and how they think about it is something you're working with. And it's hard for people to shift over. When using screening tools, there's a whole instruction set that I sent out with you. It's helpful to think about how to do, if you're going to use tools, to do it in a way that is efficient. The TAPS tool is a very short screener that was normed for people in primary care. So it's a very helpful starting place in a busy prescriber practice. The Assist is available in online versions that people can do on their own, and it gives more detailed information. And the Midas is a specific tool that I developed for screening for substance-related challenges that occur in people who have serious mental illnesses and are embedded in the mental health system, and ask problems that are directly related to the impact of substance use on your journey as a person with serious mental illness. So that may be of interest to you guys, and it's part of what we handed out. I'm not going to go into the drug screening thing. There takes too much time to go through that for the moment. Okay, so in order to make a diagnosis, as I said, you want to build it on history. And one of the things is that may help you if many people will have an established mental health diagnosis, and it's a good idea to assume that even though it may be incorrect, it's a good idea not to re-diagnose people that you've only just met. And to sort of start working with them on the assumption that their previous diagnosis is accurate, and that over time, at the same time, you're going to be involved in getting to know them better and potentially reevaluating as you get to know them better. For the diagnosis of SUD, you're looking at evidence of lack of control in the face of serious harm. Tolerance and withdrawal may be present, but those things can be present for people taking medication as prescribed. Save your questions for later. Thank you. And are not necessary or sufficient for simply making a diagnosis of substance use disorder. Okay. So I'm going to go forward into talking about the challenge of diagnosing substance-induced disorders. And part of what's being covered here is that the term substance-induced disorder gets us all thinking about cause. So a lot of times people get lost in prescribing and thinking, well, this is all caused by substance use, therefore I'm not going to treat it as a mental illness. The thing about substance-induced disorders is that although the term implies causation, the diagnosis is much more about course than about cause. And so what I'm showing you in my bad drawing is the course of someone with a substance-induced disorder. And it's a very narrow set of people. And basically during time period A, there's a person with no symptoms of the disorder in question. During time period B, they begin using substances of a type and amount that results in the emergence of a set of symptoms that is related to those substances, like using methamphetamine heavily and beginning to be psychotic. And in time period C, the psychosis emerges. Now, the first thing about this is whether you think a psychosis is substance-induced or not, it needs to be treated. Okay, just like you would treat a medical condition that may have something to do with alcohol use. It's a real disorder. And in the moment, if you think it's substance induced or you don't know or whatever it is, it needs to be treated and taken seriously. Now, at time period D in this trajectory, the person stops using methamphetamine or whatever the substance is that's potentially causing those symptoms. And here's the key: within 30 days, for this to be a substance-induced disorder, those symptoms completely resolve. Completely. If they don't do that, then you don't have a substance-induced disorder. Okay, and that's what this slide says. Okay. Now, here's the thing: if the symptoms were already present and they get worse, it's a substance exacerbated serious mental illness. It's not a substance-induced disorder, and it needs ongoing treatment. And that can often be missed if you're not looking for it. If the symptoms emerge for the very first time during the substance use, and after 30 days, they're a lot better, but they haven't gone away, then you have to think of it as the onset of a mental illness. Doesn't matter how it got there. What matters is it stays there and it needs ongoing care. And it's very common that some mental health symptoms, as I said earlier, get worse when the substance use stops because of the rebound. So you can't be expecting that things you're seeing are just going to go away. Some may get better, some may stay the same, some may get worse. And the best way for you to learn this when you're meeting someone is to learn about what happened the last time that they stopped for any period of time. Now, because of this, 30-day period, one of the things that's very interesting diagnostically is if you're not seeing someone who has a very clear history in the moment, it becomes very interesting to get information about the last period of time they were either completely abstinent or mostly abstinent for any extended period beyond 30 days. And they get very interested in what their baseline mental health status was during that period. And that's, for me, as an assessor, without a whole lot of time, that's one of the most important things that I am interested in for somebody that I may be just meeting who has an unclear history. Okay, because that information is your best guess at what their baseline mental illness may look like. And it gives you a good starting place for working with them over time to initiate or continue medication that may be helpful or may have been helpful in the past. Okay, so applying this further to psychopharm, here's the stuff that we're doing. It's not an absolute science. You're working with people who have multiple issues. You make your best guesses at the beginning, and inside the relationship, you continue to learn with them. And that's exactly the right thing to do. It's not like if you were somehow more brilliant, you would know all the answers right away. And it works best in this ongoing partnership relationship with continuous reevaluation. You're always working with them to help them with the highest order of hope and the possibility of dual recovery. You're doing stage match interventions. You're teaching them skills and small steps to make progress. And you're always making sure that as a prescriber, to the extent they have necessary treatment needs with medication, you make sure they get them and you don't withhold them. And just like, people in methadone treatment don't have their methadone stopped because they're using alcohol, we maintain medication for mental illness. And I'll go into that in a bit. So in the framework, as based on what I've been saying, the first priority is make sure people get connected to you as soon as they can, and that you don't lose them in treatment, because you're not going to be able to help them if they're not there. Okay, so it's real important to keep people engaged, and there are different ways of titrating that engagement based on who the people are, but these are folks who need ongoing attention, not only from the prescriber, but from the whole team. And prescribers should use their teammates as helpful extenders. No barriers to initial assessment based on length of sobriety or and no barriers to substance assessment based on whether people are on benzodiazepines or not. You just get in there, get to know them, get a history, and start moving. Very important in the spirit of dual primary treatment. Diagnosis-specific treatment for each disorder simultaneously. And that includes psychopharm decisions. For SUD, you distinguish misuse, which is not something you medicate, from substance use disorders, which you do medicate. Now, back in the day when I started out, like 40 years ago, medicating people with substance use disorders was rare. And then it's progressively become more common. Today, if there's a medication that you can use for a substance use disorder, the recommendation is that it's the first thing in your toolkit to be considered and offered, along with everything else that somebody may take advantage of. And so we'll talk about that specifically around alcohol and opioids. And then we'll talk also about where we're evolving with stimulants and so forth, so that people can be thinking about it, because you're thinking, not that the medication is going to fix people. I mean, occasionally that's true. But that the brain's on the other team, and we need to offer every possible tool to help you gang up with your own brain. Okay. So all of the approaches that are recommended for people with addiction psychopharmacologically are appropriate and recommended for people with co-occurring psychiatric disorders of any type. And the bottom in bold is one of the most important rules. For someone with a known or presumed psychiatric disorder, just as you would with a medical condition, continue to use best non-addictive, and there are even some exceptions to when you would use potentially addictive medication for that disorder, regardless of the presence of the co-occurring substance. And if you're worried about a person, monitor them more closely. Do not kick them out of treatment. Okay. So here are some guidelines about that you all should think about in terms of psychopharm around addiction for people with co-occurring conditions. So over on the left, we have naltrexone on the upper left-hand corner. And as you know, naltrexone is available both orally and through a long-acting injectable preparation, 30-day length, called Vivitrol, which is the brand name for long-acting naltrexone. And let's start just with looking at the way this is used for alcohol, and then I'll flip over in the upper right. You're seeing medications for opioid use disorder, methadone, buprenorphine, and then naltrexone is also potentially valuable for those as well. So one of the things that has become clear is that we have a whole new way of thinking about medication for addiction now, and naltrexone and acamprosate for alcohol use disorder are good examples of that, in the sense that these are termed broadly anti-craving agents, because the way in which they work is not directly about the effect of the substance, but to intervene in the the brain pathways at the neurotransmitter level that create the part of the brain that's on the other team, the conscious or unconscious craving that is triggered by a variety of internal or external cues, or that trigger a lack of control if the person happens to use. So naltrexone is an opioid blocker, and then it interrupts an endogenous opioid endorphin pathways that are associated with both the enjoyment of alcohol and the lack of control of alcohol use. So when people are taking naltrexone and they drink, on the average, the things that happen are reduction of alcohol craving. Doesn't happen to everybody, but for those people that this works. And when they drink, it's less fun. So it's easier for them to not lose control. And this can happen even when they're not substantially trying. I mean, not that if they work hard enough, they can't overcome it, but it helps people who are not even like super highly motivated to shift. So it can become helpful for people who are not even thinking that abstinence is a goal. And people don't have to be abstinent to be on naltrexone. So where we've gotten to in the mental health world, I know there's been a lot of attention on helping everybody learn to prescribe buprenorphine and like this, and for good reason. But naltrexone is really easy to use, and it's potentially very valuable as something you should consider for every person who you're dealing with in a mental health setting who has co-occurring alcohol use disorder, and people in substance settings as well who are there. And so one of the things to look at, just as a simple quality improvement activity, is how many of the people we're serving who have alcohol use disorders are getting naltrexone. And think of it as an improvement activity, because the odds are, based on my experience across the country, that it's way less than what it could be. Now, naltrexone orally is fairly easy to prescribe because it's a pretty long-acting medication. So, it's helpful to have people take it every day, but you can even get away with having people take it, 3 times a week, like 50 on Mondays, 50 milligrams on Monday, 50 milligrams on Wednesday, 100, 150 on Friday, and that'll cover you. So, for folks like that, that's helpful. And then if folks are willing to take the long-acting, then it makes it even simpler. Acamprosate does similar things, but through a different mechanism. It's more involved with GABAergic pathways. But the challenge with acamprosate is that it tends to need to be taken 3 times a day. So it's a little harder for folks to use, but still valuable because there are people who will respond to the one and not to the other. And then disulfiram or antabuse is still something that folks should be aware of for those people who would actually think of antabuse as a super helpful tool. Like, I'm taking this every day and I know I'll get sick if I drink, and I'm an impulsive drinker, so this will help me. And there are people with serious mental illness, and there's ancient literature on this that found this a very useful thing to do. Interestingly, disulfiram increases dopaminergic tone. So sometimes people who are on antipsychotics need a little bit more, but it also helps to reduce stimulant craving for some people. So it's an interesting thing to think about. I'm going to talk a little bit about naltrexone in other instances, but let's move over to opioids. Now, it's increasingly an expectation that people with opioid use disorders should be identified and treated in both medical settings and in mental health settings. Okay, now methadone requires special program for folks who, require the most close monitoring and the most complicated things. So for those of you who are working in mental health settings with people who have serious opioid use disorders, who are not able to be managed effectively, having a good relationship with your local methadone program is a great thing to do, and to be not only have referrals, but to do cross consultation so that they can work with people who have more severe needs, mental health needs. But everybody should now begin to practice prescribing buprenorphine, even if what you're doing is trying to do it with just a few people. So you begin to learn how to do it and find people in your area who are more familiar with it, who are willing to provide you with a little coaching. And buprenorphine is now available in a variety of both short and long-acting preparations. It's as you know, it's a partial opioid blocker. So it covers a certain amount of the withdrawal while reducing the craving, and a lot of people will do extremely well on it, including people with co-occurring mental health conditions. Naltrexone is also extremely valuable in the opioid use disorder treatment for people with co-occurring conditions. And it's, a lot of folks who are moving through the criminal justice system now are finding that while they're in the criminal justice system, an initiation of long-acting naltrexone as an opioid blocker that has the dual function of potentially making continued opioid use unrewarding if you stay on it, plus for those people whose opioid tolerance is shifting while they're incarcerated, if people are leaving the incarcerated setting or any other long-term care setting on naltrexone, the risk of them immediately overdosing because their tolerance is shifted and now they use what they used before and they overdose on it, or they're using, something that has fentanyl or some, like fentanyl, that they're unaware of, the naltrexone is protective. So for those people that are willing to move in the direction of long-acting naltrexone, that's valuable, and it's something that people should be considering. Now, for all of these medications, there's a tendency for people to think, like, I can be on this for a short time, and if they work, then I can just stop. However, remember that addiction is a brain disease, and the brain disease doesn't go away because, just like mental illnesses, just because the medicine is working. So if people stop using these medications, particularly with opioids, their brain is still on the other team. And they may feel that they deserve to stop because they've been good. That doesn't change the equation that if they're stopping the medication, they need even more help to gang up with them against their own brain, because their brain is still going to be telling them there are reasons for them to get high, all kinds of internal and external triggers. So keep that in mind. There's no, it's just like dealing with any other long-term illness, that people need to be on the medication as long as they need to be on the medication in order for it to be successful. And the getting off of it is something to be considered, but it's not something that is taken lightly. There's been some literature up and down about using N-acetylcysteine for reducing marijuana use. And I don't know how robust that literature is. I'm not super convinced, but because NAC is so easy and it's so inexpensive, it's not very harmful. So it's something to consider. And as you probably know, there's a fair bit of literature that's bubbling along around how the anticonvulsant mood stabilizers tend to have other effects that lead to people reducing their alcohol use. And so that's something to be considered if you're using those medications anyway for bipolar disorder or other mood instability disorders or anxiety disorders. But it's not enough that you would use them on their own for that purpose. Now, I'm sure most of you have heard the GLP-1 agonist like Ozempic. There's progressive information coming out about how those, similarly to the mood type, seem to cause people to use fewer substances, alcohol in particular. We're not at the stage yet where people would be prescribing it for that purpose. If people are on that may be a benefit. But we, obviously we're in a phase now where we're learning a lot more about potential utilization of medications for addiction. One of the things that, is a big frustration for folks is the lack of medication available for methamphetamine in particular and for other stimulants. And, I've been doing this for a long enough time, so I know there's always excitement about the next latest, greatest thing, which then goes away. And what I've been hearing lately is there are a few little pilot activities that are suggestive and are worth considering. So I've been working with some folks out in California who are working with people who have long-term schizophrenia, or other psychotic illnesses, as well as methamphetamine use. And some of them seem to respond well to a combination of long-acting injectable antipsychotics with long-acting injectable naltrexone. And likely for the same reasons that naltrexone works on endogenous opioid systems that are attached to craving. It's conceivable that could be beneficial to folks who have gotten into control of their meth use and want help or support maintaining that control. So it's something to consider. It's something that if people are willing, they may be open to trying. and may be helpful. I have another person here in Arizona who has a little case series of using Vyvanase for some folks with methamphetamine use disorders. That's an interesting stimulant preparation. And she reported that, with the people she used it, that was very helpful for them. And they were folks without a diagnosed attention deficit or hyperactivity disorder. Seemed to help them with their meth use craving. Again, people are trying these things, and I hear lots of anecdotal evidence of this working. But you have to do it obviously carefully. It's not approved. There's not a whole lot of research to support it. I can't say it doesn't work, but I also can't say go ahead and do it, and so on. So over on the lower left, just as you know, tobacco is the thing that will kill more people than all the other substances combined. And so paying attention to addressing tobacco use disorder in people with co-occurring mental health conditions is important. Varenicline has a robust literature base now that would be the first choice to help people reduce their nicotine use. Now, a couple of things to think about on the mental health side. One of them is clozapine. A lot of times, there's a whole issue about people with treatment refractory schizophrenia not getting clozapine, even though it could be the thing that is just life-saving, if you will. And people with co-occurring substance use issues are even less likely to get clozapine because of all the attendant difficulties in adherence and so forth. But nonetheless, there's a fairly robust literature, most of it from like a few decades ago, showing that people who are on clozapine tend to use substances less compared to other antipsychotics. And there are a variety of hypothesized mechanisms for it. But in and of itself, what this should be like, if you're working with someone who does not have a completely remitted psychosis and they're struggling with substance use, and you can get them on clozapine, that's a good thing. And you should consider moving in that direction if at all possible. Okay. With regard to mood stabilizers, it's important to follow the rule that the best medication for each primary condition is your starting place. Clozapine fits into that for psychosis, regardless of the status of the other condition. So for treating people with bipolar 1 disorder in particular, lithium, even though there's no good evidence that lithium helps people reduce their substance use, lithium can be the first choice, and you should use it if that's what's indicated. And that's true even though the other medication, the anticonvulsants, may have an impact on the alcohol use. That doesn't mean you shouldn't use lithium in people with co-occurring conditions if that's what's going to be the best stabilizing medication for their bipolar disorder. So you have to go through that lens. What's the best medication for their bipolar disorder? And then if I'm going to add additional things that may also help their co-occurring substance, because bipolar disorder has the highest comorbidity of substance use of any of the psychiatric disorders. And so you're normally going to be dealing with both of those things, but helping to control the bipolar disorder is very important. And then any kind of antidepressants that are non-tricyclic, non-MAO may be helpful for people who are suffering from major depression, who also have a co-occurring substance use disorder of any type. And it's very important to think about the fact that there's a reasonably solid literature base that shows that people who meet criteria for major depression, even though they're still using, if they're taking their medication properly, they're going to be less depressed and they'll have better outcomes. Now, with regard to anxiety, let me just finish this slide and then we'll have a question or two. There's a whole discussion about benzos, and we worked on this, in a SAMHSA project I did several decades ago. Clearly, benzos are potentially addictive. It's almost impossible to tell for someone with addiction who's going to get in trouble with benzos and who isn't. So it's better not to use them or initiate them if you can, as a first line approach for treating anxiety disorders. Nonetheless, there are people who are on benzos for anxiety disorders who are in recovery from addiction and stay that way and do fine. So neither should benzos be a never, never. It's just something you have to do very carefully. And it's a good idea to get a second opinion if you're considering it. And there's a whole set of interventions that I teach people about what happens when you inherit people on benzos that we're not going to have time to do today. But there's a slide about it. However, there are other things to help people with anxiety disorders and anxiety related to the likelihood of long-standing trauma with upregulation of the adrenergic nervous system. And those things are listed here. Clonidine can be very helpful in the short term because of its ability to downregulate the adrenergic system. SSRIs, SNRIs, buspirone, things like that can be used for anxiety. They take a while. And people need to understand that you're treating a disorder. You're not providing them the same quick relief than with rebound that they would get from using something that, they would normally use that gets them high, like drinking. And for ADHD, we're still looking at non-stimulants like atomoxetine as a first line for people who have active substance use issues. However, the stimulants, long-acting stimulants are still a better treatment for adult ADHD for many adults than they'll work better than the atomoxetine. So once people get to a reasonable degree of stability, they may need to be shifted if they have actual ADHD, as opposed to they just tell you they have ADHD, to long-acting stimulants. And the diagnosis of ADHD requires good history taking, information about what people were like when they were kids, and the evidence of persistence of those symptoms over time. But then for some people, they're going to do better on the stimulants. And for for children, using stimulants in adolescence for ADHD is protective of later substance use disorder development, because the ADHD is treated, is less likely to progress to an ongoing co-occurring substance use disorder. So there's a whole bunch of other stuff that we could cover that we don't have time to cover. I'm sorry about that. But if there's a question.
So Cassandra wanted to know what percentage of patients with co-occurring disorders are prescribed overlapping controlled substances. Do you have an idea of how often overlapping prescriptions are medically necessary to effectively manage symptoms when weighed against the health risks?
So I don't know the percentage of people. I don't think there's good data on that. And I'm not sure what when you're thinking of overlapping controlled substances, exactly what we're talking about. It's better to think of it in terms of categorization. There are people who may have co-occurring ADHD and a substance use disorder. There are lots of different kinds of substance use disorders. There are people with, as this slide is showing you, chronic pain syndromes. There are people who may be within the world of people on chronic pain. There are people who may or be appropriately medicated with long ongoing prescription of opioids who may have other substance use disorders at the same time. And so the best thing to think about doing is to think about what is the best medication for each condition moving forward to resist the use of initiating controlled substances in people with substance use disorders, period. Not to do it in people who are out of control with their substance use. And then there's a whole thing about what to do if you've inherited people who have controlled substances on our ongoing substance use. And the short answer way to do that, there's a slide on it, but it's a much longer discussion that we can get into, is the most important thing is you want to build that relationship and have that person keep coming. And then you want to get good information from previous prescribers about what was going on. And then you want to establish with the person the idea that if in fact that medication, the prescribed medication, is something that's needed for them, like they're on benzos, then if you're going to continue it, they need to be able to stop using substances. And if they can't, then you're going to gradually decrease it to help them get off of it and develop alternative strategies. But you want to keep them in relationship. And it's a complicated little dance, but it's a very important to have an organized approach with, policies and procedures that are very welcoming of those folks, and not to be treating them as if they're criminals, but to help them move in the direction with you toward the most healthy outcomes that they can. Conversely, if the benzo is very helpful and they stop using and they're doing well on the benzo, so that's why you want to keep those possibilities open as you're moving forward in the relationship. That's the short answer, as we're running over time, of a very complicated question, but it's a good question.
And then one last question, and we're only asking it because multiple people have pitched in that they also want the answer to this. Do you have any experience with low-dose psychedelics in substance use disorder?
No. And I would be pretty nervous about it. Okay. The issues with the using psychedelics for a variety of different things at this point, it's one of those things where there are a lot of people talking about the promise of doing that. I would not myself look somebody in the eye and say, oh, I feel solid that this is going to be more helpful to you than not. If someone's going to go off and do it on their own, I'm not going to hate them. I'm going to be curious as to whether it's helpful for them. But, the hardest part of this work is recognizing that, there's stuff we know and we want to do what we know and what works. And, we're not looking for magic. People are often looking for magic, and that magic stuff, sometimes it's helpful for brief periods and often it's frustrating. So you just want to be in there with them if they're discovering these things outside of what you're doing. But I wouldn't be recommending it to anybody at this point. There's just not enough good information and enough to be worried about.
Thank you so much, Dr. Minkoff. And thank you so much, everybody, for joining us today and for staying on a little extra.